On va poursuivre ce programme ambitieux aujourd'hui sur cette question de la pérennisation, de la capitalisation des expériences des autres. Et pour ça, on part dans quelques instants au Pakistan. Saleem, Sayani, est-ce que vous nous entendez bien? Parfait. Alors, merci beaucoup. Vous êtes directeur du Centre de ressources en santé numérique de l'Aga Khan Development Network. Merci de participer en direct aujourd'hui à cette conférence. Et vous avez tenu à partager avec nous les retours d'expérience de programmes de e-santé au Pakistan. Et je vous laisse donc la parole pour une trentaine de minutes. Et pour vous, je rappelle que vous regardez en direct, sachez que vous avez la possibilité d'adresser toutes vos remarques, toutes vos questions, et qu'on les posera à Saleem Sayani à l'issue de sa présentation. Voilà, Monsieur Sayani, je vous laisse la parole.
Thank you. I appreciate this. So, as you know, my name is Saleem Sayani, and I am the Director for Digital Health Resource Center for Aga Khan Development Network. And I am also the Director for Technology Innovation Support Center for the Aga Khan University. Do I need to pause for translation, or I just go?
Allez-y, on déroule la présentation en même temps.
You do not need to wait for translation. I do that simultaneously, sir. So you can go ahead. Thank you.
Fantastic. Thank you. So I'm here to talk to you about a project, a very successful implementation that we have in Pakistan. That is called Hayat project. Hayat in local language means life. So this is a project to digitize the entire process of MNCH, maternal neonatal child healthcare services, starting from antenatal care to delivery to postnatal care, child growth monitoring, family planning, and then all that. So let me just briefly talk about how it all started. So in 2018, government of Pakistan in Gilgit-Baltistan and Khyber Pakhtunkhwa, these are two provinces in Pakistan, in the northern areas of Pakistan. So they came to us, the Department of Health, they came to us and they said, well, we need Aga Khan University's help to this entire process of vaccination and also MNCH care. Right now, we have people, we have lady health workers, we have vaccinators, they go out in the field, but we don't know, we cannot monitor them real time. So how Aga Khan University can help us in strategizing and developing a solution that is digital solution that will help us create more transparency in the process and more accountability for the work that is being done. So we sat down with our stakeholders, we went through different brainstorming sessions, and we came up with a solution that is that had two parts. One is a mobile application, and the other one is web portal. So what mobile application would do is that it would actually convert all this data collection that was happening in the field on the paper into a mobile application. It was HL7 compliant in terms of architecture. It had personal family health records, so it has not EHR, but PHR, which is personal health record for individuals. And then it can have a tracking for all these vaccination and other services that are provided by frontline health workers, such as lady health workers, vaccinators. It also had a module for COVID-19 vaccination tracking. And also, one thing which was very important is that it had an awareness session video content, so that we standardized entire health promotion messaging. So if there is a message about family planning, it is a consistent message that is videotaped, and it is a short video for 30 seconds, maybe 90 seconds, from 30 to 90 seconds about that topic. So you as a health worker, you don't have to think about how you're going to communicate that message to the pregnant woman or other family members of the household, but you can simply play that video, and that those videos are in local language. And then there is this other portal, other part of the solution, that is web portal. The web portal is a centralized server, and it provides geo mapping and tracking of all activities of all healthcare, frontline healthcare workers. So if you are a vaccinator and you are supposed to be in village A on Monday at 9 a.m., your supervisor sitting in his or her office, in the head office, can I see if you are actually there? And just important that you being there, if you perform a certain task, for example, if you are a vaccinator and you're vaccinating a child, your color of your tracker changes from red to green, so that your supervisor sitting far flung can actually see the workload that you had, and also the amount of work that you're performing every day. So this provided a lot of transparency and accountability in the entire process. Now, one of the challenges that we face, and I heard this earlier in the session, that the geographies that we work in low and middle income countries, we don't have luxury of having internet connection all the time. So we took that into account, and we make sure that our application, the solution that we have, Hayat, is an application that works in an online mode as well as offline mode. So that where the geographies or the villages where there is no connectivity, healthcare worker can go out in the field, perform the task, and then come back to the health facility where there is internet connectivity, and then can upload the data. It is a very similar concept like in North America. If you go to Starbucks or in Europe, you go to Starbucks or Dunkin' Donuts coffee shop, you have Wi-Fi hotspot, and then you can upload your data. So it has worked very well, and that is why as healthcare providers and also technologists in e-health space, we always think that we need to have a real-time information, but we need to also think about close to real-time information, where we don't have infrastructure, right? Next slide, please. So this is to give you an idea about the application. This is a screenshot of different screens of the application, Hayat application. So you can see that this application mostly is bilingual in English and in Urdu, but mostly in Urdu, so that there is no learning curve for healthcare, frontline healthcare workers, because they are well aware of the language, Urdu language, and this entire application is in Urdu. And we also have QR codes. So once you scan the QR code, we can just extract information about your family, about your health record, and then the health record of your household. Next slide, please. And these are some of the pictures, and it gives you the context of where we work. So this is a mountainous area in northern Pakistan. It borders China and India, so very close to the border, and very difficult and hard to reach valleys and areas where sometimes you don't have access to people because there's a landslide or there's snow that you cannot even travel. But that does not mean that people living in these communities, they don't need health services. They do. And one of the ways to provide better health services and access is digital health or e-health. And at the bottom, you see on the left, the educational videos are shown on a mobile phone, not having internet connection, so that people can learn more about different topics such as birth spacing, such as family planning, such as child growth monitoring, and others. Next slide, please. So these are some numbers that I would like to share with you in terms of beneficiaries of Hayat project. So as you can see that we have registered, there are about more than 43,000 children under 2 years over the period of last 3 years that we have registered, and adolescent women especially from 15 to 19 years of age are about 42,000, close to 43,000. And then from 20 to 49 years of age, we have about 163,984. These are the beneficiaries who benefited from this Hayat project one way or other. So as you know, in Pakistan, the person who is head of the household is usually husband, but the person who actually makes decision about pregnancy and where a woman is going to be delivering, that is mother-in-law. So this number shows the inclusion of mother-in-law in the household. And also, you can see that pregnant women who receive 4+ ANC visits is about 9,446. Now, what used to happen is people did not have enough awareness of why they should get antenatal care visit, let alone 4 visits. So we created that culture, and then through our behavior change messaging, we made sure that people are aware why ANC is necessary, antenatal care visits are necessary, and how they can help reduce complications earlier in the pregnancy so that you can have a successful delivery. Now, also, there are some numbers about the children with basic vaccination, about more than 30,000 in that catchment population. And we conducted about 187,000 awareness sessions for different folks. And this application is used by frontline health workers, as I said earlier, and there are about 530 health workers. They are using this application. Next slide, please. So how this application actually, as you can, I'm sure you have similar structures in your respective countries. So there is an EPI component in health department, which is assigned for vaccination for children. And then there is a lady health worker program, which are, sometimes you call it community health workers, lady health workers, community midwives. So these are the workers, health workers, they provide MNCH related services in field. But the challenge was in Pakistan that these programs, they did not talk to each other. So these are vertical programs, but they did not have any collaboration or coordination within the programs. Can you go back to the slide, please? Thank you. The next one. Yeah, thank you. So we made sure that through this platform, through this application, there was an integration between 2 programs, and there was close to real-time monitoring that I talked to you about. We also made sure that there was a transparency and accountability mechanism through this application. Something that is very important is that we had buy-in from the government in Khyber Pakhtunkhwa and Gilgit-Baltistan so that this program can be sustained long-term. So now I'm very happy to report that the initial phase of this program has been now taken over by the government in Gilgit and Baltistan, and also in Khyber Pakhtunkhwa, so that they are now paying for the operating cost of this program, like connectivity and other stuff. So that is very important for any program to be sustainable. I heard about sustainability earlier, that you need to make sure that government of that respective country, in this case Pakistan, is fully on board so that if we show successful results, they are willing to take over the operation. And it is not a project that has a start and finish date. It continues as a program. Next slide, please. So this is what we are planning to do moving forward. We are actually scaling up this project in Gilgit-Baltistan in 5 additional districts. And I'm happy to report that actually this is partially funded by the government based on the result that they've seen earlier. So that is a good sign. We are also adding some features and functionality into this application. We are now adding another module to it, which is related to non-communicable diseases. And we are going to integrate DHIS2 so that there is a direct reporting to the provincial level into DHIS2 system. And of course, as I said earlier, that we work very closely with the government so that we can achieve long-term sustainability, be it in Khyber Pakhtunkhwa or Gilgit or in any other country. So with that, I will conclude this presentation, and I'm very happy to answer any question that you may have.
Merci beaucoup pour cette présentation, Saleem Sayani. Effectivement, pour me retourner vers cette salle et puis aussi vers les internautes. N'hésitez pas à nous adresser toutes les questions. Est-ce qu'il y a des questions par rapport à ce projet Hayat qui nous a été présenté par Saleem Sayani? Alors, on va vous apporter un micro. Voilà, tout de suite. Hop, pas de course.
Yes, please jog, run around. Here we go.
I'm going to speak in English. Thank you very much, Doctor, for your presentation. I have a question regarding the acceptability of the tool and sharing a little bit the experience we had in Afghanistan, where we gave tablets to the midwives while they were doing the household visits. But then we found that they were still collecting data on paper and then coming back home and then digitalizing everything at home, basically because going to the household with a tablet was not acceptable by the community. So I just would like to know how that happens. Of course, Afghanistan is not the same as Pakistan. The situation is very different, but culturally could be similar. And I would like to know how that goes in Pakistan and how the communities have been reacting to this. Thank you.
Very good question. And so what I did not mention in part of my presentation was that this Hayat project was implemented in Pakistan as well as in Afghanistan. So we had a very successful implementation in Afghanistan of Hayat project. And there was no issue that we faced in terms of community health workers taking mobile phone out in the field and collecting data. What we actually modified from our approach in Pakistan, in Afghanistan, was that we changed that application and the way people collect data, because as you can tell that in Afghanistan, the literacy rate of healthcare worker is comparatively low than the literacy rate in Pakistan. So we made sure that they are comfortable in a way to collect data so that they don't have to learn anything different, right? So the user interface was very different, and it actually depicted the way they were collecting data on paper. And sometimes we see that that is usually the problem, that when people don't say the real cause, they have all these smoke screens. So if you go through those smoke screens, in my opinion, we find the real cause. And if we address that, then there's a problem. Culturally, I did not see any problem, and we did not face any problem. But you may have implemented the project that you talked about in more challenging province than we implemented Hayat in. So we implemented Hayat in Bamiyan and Badakhshan. So I hope that answers your question, partially maybe.
D'autres questions, d'autres remarques, madame?
other
Oui,
questions or comments?
bonjour, merci. Je vais
Well,
parler
thank
français.
you. I'm going to ask my question
Tout
in
d'abord,
French.
merci beaucoup pour,
Well, thank you very
pour
much for this very
tous ces
bright
partages qui sont très
presentation,
intéressants.
for sharing
On parle de
all
pérennité.
those learnings. We're
Et
talking
du
very
coup,
much about
je
sustainability.
souhaiterais poser la
And
question
therefore, I have
de
a
manière peut-être un peu
question.
plus large
Maybe
que
I'm going with
l'expérience, mais
a
aussi
broader scope.
l'expérience actuelle
We
de
also
ce projet,
conducting an
sur notamment
experience
tout ce qui est maintenance
on
des équipements
everything
qui
that
sont
has to do
utilisés.
with
Parce que c'est
maintenance
souvent
of the
un
different
des problèmes
devices. Because this is one
récurrents,
of the problems
c'est-à-dire que le
that we
projet
keep
se fait,
facing. So the
mais
project
quid de la
is being
suite, et
rolled out.
notamment en
Now
termes
what
d'équipement.
happens when the devices
peut-être
become
poser la question
older, for example?
à
So we're going to
Salem
ask the
Sayani,
question to
savoir déjà
Salim
lui,
Sayani.
au Pakistan, comment
Did
il
you
assure
face this
la
problem? How
maintenance
do you
ou le rachat
maintain the
éventuel de
devices?
ces équipements?
Or maybe do you repurchase equipment?
Yeah, very good question. And when it comes to sustainability, we also sometimes forget actually to include the upkeep of the hardware. So we included that, and we have a technology refresher or equipment refresher cycle for 3 years. So we change our equipment after third year. We started changing at the 33% rate. And when it comes to who's going to fund it, so initial funding was provided by the donor, but later on, how to sustain it and then keep changing it was part of our agreement with the government. So now, as I said earlier in my presentation, that government is actually paying for connectivity and the devices if we need to change devices. And that is a big achievement because usually we don't see that in donor-funded programs. And that is why sometimes, you have a start date and end date, and then when funding ends, the project ends. So we made sure that we don't get into that cycle for this project. So we started collaboration from the design phase with the government so that they had ownership and still have ownership of this project. And now they are scaling this up, working with us in 5 additional provinces, for example, in Kyrgyzstan, and they are actually funding most part of it.
Monsieur, une autre question.
Another question
Je
here
me
from
nomme
the
Kawele
gentleman.
Bozum. Je suis le point focal
Mr.
de
Kayozun,
la
I am
e-santé
the
au
focal
niveau du
point
ministère de
in
la Santé
e-health at
du
the
Togo.
Ministry of Health in
J'ai une
Togo.
préoccupation que je devais
I
soulever
have a
depuis.
concern I would like to share with you.
Ça me tardait, c'est depuis les
And this, of
interventions
course,
précédentes.
I don't want to speak too
Maintenant,
much
je vais la
because I
soulever.
know that there's still a
En fait,
busy
je voulais
agenda.
juste savoir,
But I
solliciter
wanted
juste
to know,
le partage d'expérience.
again, in the purpose
de
of
certains pays.
sharing
Je
experience,
voulais,
I
avant
would
l'arrivée
like
de
to
la
know,
santé numérique, il y avait des systèmes d'information sanitaire dans presque tous les pays
before
déjà.
you went for this
Ma
digital
préoccupation est de
solution,
savoir,
I suppose that you already had
concrètement,
a
comment on a
digital
pu
health
intégrer la
system,
santé numérique au
and I
système
wanted
d'information
to
sanitaire.
know how you
Donc,
also integrated the training of staff
pour que ça puisse
in
quand même
e-health, so
bien marcher
that
et puis
it can
sans qu'il y ait
work
confiner
very
la
smoothly,
porte.
so that you don't have to
Merci.
retrain
On va
everybody.
pouvoir poser cette question à Salem Sayani, savoir comment
We
vous
are
avez
also
pu faire
indeed
au
going to ask a
Pakistan,
question,
effectivement,
Mr.
pour intégrer
Sayani.
des
How
systèmes de
did
santé
you
digitaux à des
integrate
systèmes
these
d'information qui étaient déjà
digital
préexistants.
systems to pre-existing systems, and how did you train the people?
Yeah, so very good question. So I'll start with training first, and then we'll go to integration. So training is very important, and it takes a lot of time. And the expensive component of training is the HR. So who is needed to provide training usually? So what we have done is that we created training modules, digital training modules on how to, on different features of the application. So whenever we hire new staff or we need refresher training, we don't have to have a trainer go all the way out in the field or call our participants at a location to provide them training. These modules are available within the application. So you can actually, if there's a new hire, they can go through different steps on how to do certain things or how to use digital health application. And usually they are trained by that. And if they have any question, we have maybe one person on site who can do some hand holding, but mostly it is done digitally. So that is to answer number one. So we did not just digitize the process, we actually digitize the training as well, so that it is just one-time effort, and after that we can use this repeatedly for the same purpose. Now, when it comes to integration, fortunately, in Pakistan there was all paper-based system when it came to EPI and also for LHW. There is an MIS program or solution, and then we integrated with the MIS system. However, the DHIS2, which is the provincial reporting system, we are planning to connect with that system so that we can integrate, so there is no paper-based data entry into DHIS2. Because we believe that integration is so critical. Without having integration, you are just creating parallel structures, which are not sustainable at all.
On retient une fois de plus, je trouve ce mot qui s'est invité dans cette conférence, alors qu'il n'est peut-être pas prévu au départ, qui est celui de la formation et compétences à chaque fois. Merci beaucoup, Saleem, Sayani, de cette intervention directe, de nous avoir décrit, on peut l'applaudir, ce projet développé au Pakistan. Et on va